Hello, good evening, everyone. Welcome to 365 Live. My name is Carmen, and I will be your host for tonight. A gentle reminder that all information shared at this event by the speaker and 365 CPS is for general information only. Do consult your doctor for personalized and detailed medical advice. Okay, without further ado, I am pleased to introduce tonight's speaker, Dr. Tan Yu Guang, Associate Consultant, Urology, Singapore General Hospital. He's also the Clinical Assistant Professor, Duke NUS Graduate Medical School. He's here tonight to talk all about prostate cancer and touch on some of the myths and misconceptions of prostate cancer. So if you have any questions, please feel free to post them during the Q&A session.
Hey, hi, come in. Here.
Hello, Dr. Tan.
Hey,
Thank you
hi.
so much for joining us tonight to share your knowledge here with everyone. I'm looking forward to know more about the myths and misconceptions of prostate cancer too. All right. So let me hand over the time to you, Dr. Tan. Thank you.
Thanks, come in. Just let me note the slides. And before I begin, I'd like to take this opportunity to thank 365 Cancer Prevention Society for the kind invitation. And certainly big kudos to the team for doing a lot for cancer screening. And I understand that your team is actually currently doing a lot of prostate cancer screening in the form of free PSA for the public. And certainly, I think this talk is very timely for the general public to know more about prostate cancer. So without further ado, I'll dive straight in. Regarding prostate cancer, should you be worried about it? And how can one screen for it? So certainly, I think in the last few months, we have heard about former US President Joe Biden being diagnosed with prostate cancer. And in fact, what he had was aggressive and advanced prostate cancer. And that really sparks a new debate regarding prostate cancer screening for older men. And to add on, they have the US Preventive Service Task Force. So that's kind of like their government-backed organization that give a preventive health recommendation. They actually advise against prostate cancer screening in the form of PSA for men above age 70 years old. And if you look at the last paragraph, former President Biden was actually last tested for prostate cancer in 2014. And that time he was 71 or 72 years old. And therefore, subsequently for the last 10 years, he did not have any prostate cancer testing or screening. So this will be the outline of my talk tonight. We'll talk about a bit more about the natural history and epidemiology of prostate cancer and how can one screen for it, and some of the treatment options for prostate cancer today. So to begin, the prostate is a gland that is unique to the males, and it actually sits below the bladder and above the pelvic floor muscle, and that actually form parts of the urinary tract for the man. And the main role of the prostate is that it produces fluid and nutrients for the sperm. And as you age, unfortunately, two issues may arise from the prostate gland. One is that of a benign prostate enlargement. That is just a enlargement of the prostate, and that's not cancerous. The second issue, unfortunately, that can arise is prostate cancer. And you can see there's actually some differences between prostate enlargement and prostate cancer. And I can show, if I can draw your attention to the right side, which is just prostate enlargement. Classically, it tends to begin in the middle of the prostate gland where the urine passes through. And therefore, in very early stages, men will present with some flow obstruction, such as, they complain of poor flow, incomplete emptying, having to go toilet many times. But on the other hand, if you look at prostate cancer, it grows in a different area of the prostate gland. Unlike the prostate enlargement that starts in the central part where urine passes through, prostate cancer actually starts from the border of the prostate gland, or what we call the periphery of the prostate. And therefore, in early stage prostate cancer, is almost always asymptomatic and you will not have any symptoms. Only in advanced prostate cancer, when the cancer has actually grow to a significant size and move towards the central part of the prostate where the urine passes through, and that is the time that you will start having some symptoms of a flow problem or even blood in your urine. And unfortunately, prostate cancer is rather common. worldwide, there's a rising incidence of prostate cancer, and it's actually the most common cancer affecting males today. And if you can look at the right, this is on the top right column, the diagram. This is taken from the Singapore Cancer Society back in 2020. And you can see prostate cancer actually ranks second after colorectal cancer. But if you look at the diagram on the bottom, this is from the Singapore Cancer Society, Singapore Cancer Statistics in 2024, 4 years later. And you can see now prostate cancer is the most common cancer affecting men. And about 1 in 7 men will be diagnosed with prostate cancer in their lifetime. However, if I were to draw your attention back to the first diagram, where you look at the incidence and the mortality, if we look at other cancers such as lung or liver, they have a slightly lower incidence compared to prostate cancer, but they have a high mortality that's highlighted in the red bar. But on the other hand, if you look at prostate cancer, despite having a very high incidence, the mortality is actually significantly lower compared to other cancer. And in Singapore, it's actually only ranked 6 in terms of mortality, despite being the number 1 cancer affecting men. And therefore, the question is really, does prostate cancer kills, and who does it kill? And it's important to go back to the natural history of prostate cancer. And suffice to say, prostate cancer does take many years to cause death, and the average is about 10 to 15 years. Therefore, for the elderly men that's above 75 years old, they are more likely to die of other causes such as, health conditions such as cardiac issues, stroke, pneumonia, other infections, renal impairment, rather than prostate cancer. Therefore, instead, only for the healthy middle-aged men aged between 50 to 70 years old, prostate cancer may become a more important condition to address. And this is actually our study. We look at 200 patients with prostate cancer that were completely untreated, and we merely monitored their PSA. And they were followed up for a median of 13 years. That means that, we are able to have such a long duration to follow up these patients. And that really highlights that prostate cancer takes a very long time to actually affect someone. And as you can see, only 19 out of 204 patients, and that's really less than 10% of them, will die of prostate cancer. And in the same period of 13 years, almost half of them actually die of other causes. And this is what you can see. The black refers to the overall mortality of our cohort. And you can see over a time period of 10 to 15 years, the prostate cancer-related mortality, which is highlighted by the red line, remains rather low. Whereas, in the same period, the non-prostate cancer-related mortality, which is highlighted in blue, is the more significant one in general. So now we'd like to talk about, I'll take this opportunity to talk about some of the risk factors for prostate cancer. Fortunately or unfortunately, there is actually not really much risk factors for prostate cancer. Perhaps the only significant risk factor is age, and prostate cancer primarily affects older men aged above 60 years old and above. So hereditary prostate cancer or inherited prostate cancer is actually very rare, and it counts for only less than 5% of diagnosed prostate cancer. And then we look at some of the environmental or lifestyle factors that can increase prostate cancer risk. So some have been studied, include that of obesity, which has been associated with higher risk of advanced prostate cancer or aggressive prostate cancer. And the other risk factor is that of smoking, and smokers may be at slightly higher risk of developing prostate cancer. I have patients who always ask me whether there's any dietary advice or, lifestyle modification that can bring down their PSA or prevent prostate cancer. So suffice to say, up till now, there's no single effective diet or medication that is known to prevent prostate cancer. But generally, what I would say is that healthy lifestyle will never go wrong. And we talk about, having a good amount of vitamins, a good amount of protein in your diet, and that's mainly the consumption of such as a tofu or bean-related milk products. There's been some talks about tomatoes being a preventive for prostate cancer. And next, we'll talk about screening for prostate cancer. And similar to the 365 Cancer Prevention Society, they are doing free PSA testing. And PSA stands for prostate-specific antigen. is a molecule produced by the prostate cells. And in fact, both normal and cancerous prostate cells will produce PSA, but in general, in prostate cancers, the cells tend to be more disorganized, and therefore you experience a higher PSA level. But PSA itself is actually organ specific to the prostate, but it's not disease specific. And in fact, there are many other conditions that can cause your PSA to be elevated. One of which is what we have discussed earlier, a prostate enlargement that's non-cancerous. The second is prostate inflammation or infection, and even if you are avid cyclist, that might also increase your PSA level. And therefore, the accuracy of PSA, or what we call a sensitivity, is actually much lower compared to other cancer screening program, such as mammogram for breast cancer or the fecal occult blood test for colorectal. And PSA, which we use an arbitrary cutoff of 4, only has a sensitivity of somewhere between 30 to 40%. And therefore, what it means is that having a low PSA also does not exclude prostate cancer. However, if someone has a low PSA of less than 4, while they might still have prostate cancer, they are much less likely to have aggressive prostate cancer, and therefore the cutoff of 4 is somewhat internationally agreed upon cutoff for the screening of prostate cancer. And we look at some of the landmark studies that look at prostate cancer screening with PSA, and this is a landmark study from the European group, and it shows that with regular PSA testing, it can reduce prostate cancer related mortality by 20 years. And they even had follow-up studies looking at 10 years, 13, and even 16 years of follow-up. And consistently, it has demonstrated that PSA screening will reduce prostate cancer-related death by about 20%. And in fact, what is more enlightening is that the number of patients needed to invite to screen for prostate cancer and the number needed to diagnose and treat for prostate cancer continues to decrease over the years. And in fact, this number that we are looking at year 16 of follow-up, which is inviting 500 patients to screen for prostate cancer and diagnosing 18 patients to treat for prostate cancer, this numbers is actually less than that of breast cancer screening today. And with that, we have some guidelines regarding prostate cancer testing. The American tend to have a harder stops. They encourage prostate cancer testing from 50 to 70 years old, but after 70 years old, they had a hard stop and do not screen for prostate cancer. Whereas for the European guidelines, they were a bit more relaxed after 70 years old. They suggest that screening can be continued if your life expectancy is more than 10 years, meaning you are generally a very fit and healthy gentleman, then you may want to continue some form of prostate cancer testing or PSA testing. And you can see this is what exactly happened in US upon the US Preventive Task Force recommendation against PSA testing after 70 years old. And that's what former President Biden had, because he was after 70 years old, he did not have prostate cancer testing. And that was a guideline that was established after 2014. And you can see after that, the incidence or the newly diagnosed advanced prostate cancer or stage 4 prostate cancer, which is what we call as metastatic prostate cancer, start to increase significantly over the next few years. And that really highlights that, probably for the very fit and healthy gentleman, you might want to consider some form of PSA testing even after 70 years old. And this is, my summary and my understanding, my advice for PSA testing. I think it's here to stay with increasing health literacy, but it's important to understand, its accuracy and limitations. I would say that it's important to select the right patient to do PSA testing. I would routinely offer to someone aged between 50 to 70 years old. After 70 years old, I will look at their health status, and if they are generally a fit and healthy gentleman, I would still consider some form of PSA testing for them. So with that, the next question is, if you have an elevated PSA, what are the next investigations for you? So for a long time, up to the early 2000s, the next investigation that a patient will undergo is called a biopsy, Basically, we are taking tissues from the prostate gland to see whether you truly have prostate cancer. And this is performed via what we call a transrectal ultrasound guided route. And you can see the diagram on the right. This is what one would go through. Basically, an ultrasound probe will be placed through your rectum. And with that, a needle will come out from the ultrasound probe and try to take biopsy through the rectum into the prostate. And this is what we call a transrectal, or in some urologists, they will call it a transfecal way of doing it. And as you can see, it's actually a very dirty way of doing biopsy because the needle actually passes through the feces before going to the prostate. And that will increase the infection of up to 5%. And the second issue is that it's a random biopsy where the needle will randomly poke the prostate gland 12 times. And being a blind biopsy, the overall accuracy with this form of biopsy is only 60 to 70%. Therefore, in 30% of patients, even if they have a negative biopsy, you cannot convincingly rule out prostate cancer in them. So what has truly been very revolutionary is that of a MRI prostate. And for the first time, you're able to see very abnormal prostate cancer lesions in the MRI. And this is a study, landmark study that look at using MRI rather than upfront biopsy. And it shows that if you go through an MRI, almost 1 in 4 patients can avoid unnecessary prostate biopsy if they have a negative MRI. And I understand that it's not uncommon that some of the patients who have gone through ultrasound of the prostate as part of the health screening, I would say that ultrasound of the prostate is useful to study the prostate size and whether there's you likely to have any obstruction to the urine passage. But it's not useful to detect prostate cancer because, as you can see on the image on the right, this is a very rudimentary way of just scanning the prostate, and certainly you are unable to see any suspicious lesion accurately. So this is our experience in the Singapore General Hospital. We have moved away from what we call the transrectal ultrasound prostate biopsy to what we call a transperineal prostate biopsy. Basically, the needle, instead of going through the rectum towards the prostate, the needle now passes through the perineum, which is the skin below the scrotum, directly into the prostate gland and bypasses the rectum. And with that, we are able to significantly reduce the infection risk to less than 0.1%. And that is a significant risk reduction compared to the older ways of doing through the rectal route. And what is really revolutionary is that, since you have done an MRI prostate and you can see some of the suspicious lesion, then the question is that can you go ahead and, just biopsy the areas that were suspicious of MRI prostate? And that's what we call a very targeted way of doing biopsy rather than randomly poking the prostate 12 times in the older days. And this is, what we have come quite far over the last 15 years. And Singapore General Hospital was the hospital that created this robotic platform that established how we do prostate biopsy today. And this is how how the biopsy is carried out today. In fact, you will, on the day of the procedure, you have an ultrasound that's performed, following which the robot will import your MRI images that you have done previously a couple of weeks ago, and we will create a fusion of the MRI that you have done a few weeks ago and the real-time ultrasound of your prostate. And with that, the suspicious lesion on the MRI will be superimposed on the real-time ultrasound. And for that, we are able to see the areas that are suspicious now. And that will allow us to use the robot to do very targeted, guided biopsy at the areas that were suspicious being picked up by the MRI prostate. And this is a short video of how it's done. So you can see this, how the biopsy is done. It's done through the skin, or what we call the transperineal route. So generally, I will tell the patient the prostate biopsy nowadays is done under a short general anesthesia, and this is a day surgery, meaning that after about 30 minutes, after you wake up and able to pass urine, you will go home on the same day. There are some minimum side effects associated with a prostate biopsy. You might see some blood in the urine, or what we call hematuria, or blood in your semen, or what we call hematospermia, for 2 to 3 weeks after the biopsy. You might encounter some mild bruising of the scrotal skin, and there's a small risk of transient urinary retention in about 2 to 3% of patients, and you might require a urine catheter for about 3 to 5 days. And overall, with this MRI followed by the robotic biopsy, we are looking at accuracy of over 90% nowadays compared to 60% in the older days. And this is the outcome of the biopsy if you unfortunately is diagnosed with prostate cancer. You know, we always talk about the aggressiveness of the cancer, and this is denoted by the Gleason score. And we use a Gleason of 6 to 10. If you have a 6, that is what we call a low-risk prostate cancer. If you have a 7, it's an intermediate prostate cancer. And unfortunately, if you have an 8, 9, or 10, that represents aggressive or high-risk prostate cancer. And with that, you know, there are actually a lot of options for prostate cancer treatment today. And 2 important considerations are that of the disease aggressiveness, denoted by the Gleason score that I talked about earlier on, as well as the patient comorbidity and life expectancy in general. So for the low-risk early-stage prostate cancer, we carry out what we call active surveillance, means that we do not need to aggressively treat them, but in fact, we can watch them closely to see whether over time the disease actually progressed to a more intermediate or high-risk stage that requires treatment. And you know, large studies have shown that with this approach, we are looking at survival rate of more than 99.9% at 20 years. So this is actually a very safe strategy for someone with low-risk prostate cancer. No, if you have intermediate risk prostate cancer or high-risk prostate cancer that is confined to the prostate gland, there are some options which will include robotic surgery to remove the whole prostate, radiotherapy, or focal therapy, which I'll briefly touch on later on. And unfortunately, if one has metastatic or advanced prostate cancer, what we give is injections or what we call hormonal therapy to suppress your testosterone level to control the disease, and you might also need chemotherapy. So this is robotic surgery. I think, you know, it has been around for many years. And in fact, the Singapore General Hospital was the first Asia center to perform this more than 20 years ago. And to date, there's more than 6,000 cases performed in Singapore General Hospital. And this is what we call a truly keyhole and robotic surgery. So generally, the robotic surgery involves removing of the whole prostate gland. And at most places, the length of stay will be about 2 to 3 days. And you will need a catheter or urinary tube to protect the area that we have removed and joined up for about 7 to 10 days. In Singapore General Hospital, for well-selected patients, we now offer same-day discharge or short-stay ward, meaning about 50% of patients can be discharged within 23 hours after the surgery. And the catheter will be inside you for about 5 to 7 days in general. So generally, prostatectomy is actually a very safe surgery with minimum complications. It tends to be about 3 to 4 hours of surgery. However, you might get transient urinary incontinence, and you will need some form of pelvic floor exercise to strengthen your pelvic floor muscles to reduce the incontinence. What I will tell my patient is that maybe in the first 1 to 2 weeks, you might need diapers, and after which you will need what we call pads, and that's what usually the females use it for the menses, and you will need about 2 to 3 pads a day for about 3 to 6 months. In our local data, significant urinary incontinence, which we define as more than 1 pad usage beyond 6 months, is actually less than 5%. And therefore, that's why we always say that urinary incontinence is transient and not permanent. Also, you might suffer from erectile dysfunction because some of the nerve that supplies the erectile function lies very close to the prostate gland. And it's important to remove some of this nerve that's very close to the prostate gland itself to prevent any cancer that's left behind. Alternative, for very elderly patients or patients who are not fit for surgery, the alternative will be radiotherapy. This can be done like a 5-day or 20-day cycle when you come for radiation for about 1 to 2 hours on a daily basis. This avoids the need of a surgery. There's lower risk of erectile dysfunction or urinary incontinence with equally good cancer control. Today, we also have proton therapy that is rather similar to radiotherapy. The only side, some of the downsides of radiotherapy is that it might affect some of the neighboring organs such as the bladder or bowel or the rectum, and that means that you might experience some urinary frequency, difficulty in passing urine, or blood when you pass urine. And last but not least, increasingly, there's this concept of focal therapy. So some of my patients, they'll ask me, Dr. Tan, I only have a cancer at a very small area of the prostate gland. Why do you need to do radiation for the whole prostate or do surgery for the whole prostate? Why can't you just try to burn the area that has prostate cancer? And that is the concept of focal therapy, where you really just treat the cancer focus rather than the whole prostate. And this is in an attempt to maintain the patient's quality of life. And therefore, focal therapy is useful for well-selected patients with very small cancer volume. And the pros of it is that, it minimizes the risk of incontinence or erectile dysfunction. It avoids complications to the neighboring organs that you see in radiotherapy. But it does have slightly higher risk. We are looking at cancer-free rate of 70% compared to 85% with traditional robotic surgery or radiation. And therefore, we will need a more intensive surveillance strategy to ensure that you do not have any recurrence. So to conclude, these are my take-home messages. I think firstly, prostate cancer is certainly common, but it's not always deadly. The urinary symptoms that many of you all talk about, such as poor flow, difficulty in passing urine, these are more likely due to prostate enlargement, because the early prostate cancer is largely asymptomatic, meaning that you have no symptoms. And therefore, I think it's important to do some form of prostate cancer screening in the form of PSA. It itself is certainly imperfect, as we have talked about, but it's often the starting point where we actually can do further investigation and evaluation for you. And that will be in the form of MRI, which will help you decide whether you truly need prostate biopsy. And certainly today, with our advanced robotic biopsy techniques, we can offer accuracy and safety, reducing infection risk and achieving accuracy of more than 90%. And certainly, I think the take-home message is that if you have any concern regarding your prostate health, it's important to speak to your primary physician, or if necessary, speak to a urologist who will be able to provide the most accurate information for your condition. So with that, I have come to the end of my presentation, and I'm happy to take some of the questions.
All right, thank you, Dr. Tan, for your insightful sharing. So here's a gentle reminder for those who have just tuned in. You have any questions, please feel free to share them in the comments, and we will invite Dr. Tan to address them accordingly. So to start the ball rolling, from Dr. Tan's sharing tonight, I actually understand that prostate cancer is actually one of the most common cancer affecting men today. So therefore, as mentioned by one of our audience members tonight, it's actually a great topic for public awareness. So with that, I would like to ask, is prostate cancer hereditary, or is it like a genetic? I think Dr. Tan actually mentioned just now during his sharing as well.
So, thanks, Carmen. So, like I've mentioned earlier, hereditary or inherited prostate cancer is actually very rare. It's actually less than 5% of diagnosed prostate cancer. Certainly, if you have a family member that is diagnosed with prostate cancer, that does raise some alarm bells. But I wouldn't say that, just because you have a family member having prostate cancer means that you are at higher risk than any other guy across the street. But because we are talking about prostate cancer having a high incidence where 1 in 7 might be diagnosed with prostate cancer in their lifetime, that certainly warrants, some form of screening or testing. And that's really the whole concept that we are trying to drive through today.
Yes, indeed. And just now, Dr. Tan did mention that, some dietary advice is actually to have a healthy lifestyle, take in good amounts of vitamins and protein in the diet. And so with that, I see some questions coming in. Okay. Okay. It's about a robot biopsy. So is there an estimate on the cost? Is it MediSave claimable for robot biopsy?
Thanks, Mr. Yu. I think that is really, a very common concern for many patients. I will talk also in the same line, same vein about MRI prostate. I think it depends where you do your MRI prostate. In the public healthcare setting, MRI prostate usually costs somewhere between $800 to $1,000. And nowadays, I know that with MediSave, you can claim up to about $500 or $600, and that will mean that your out of pocket cost is somewhere about $200 to $300 for MRI prostate. For prostate biopsy, it does cost a bit more. I think we are looking at somewhere between 3 to 4 thousand, and that is MediSave claimable. And most of my patients in the public setting, I think their out of pocket is somewhere less than $1,000. And in fact, I think depends on the your subsidy. You might not even have to pay a single cent out of pocket.
Thank you, Dr. Tan. And then you also mentioned that actually prostate cancer takes a long time to affect someone. So we have a question. How often do we do PSA screening?
So I would say that above 50 years old, you should consider some form of PSA screening. If you have a truly normal PSA, so it's less than 4, even less than 3, I would say your next PSA screening will be somewhere between 2 to 3 years. So I don't recommend having PSA screening or PSA testing every 3 to 6 monthly kind of picture. If you have a normal PSA, then the next time you should do it, according to most guidelines, will be about 2 to 3 years. And that's what I do in my clinic. If they have a normal PSA, I will tell them, you can go to their GP or even polyclinic to do your next testing about 2 to 3 years time.
Yes, so it's recommended for men above 50 years old to get screening in about 2 to 3 years. All right. And we have a follow up question on how accurate is PSA?
So, I've mentioned in my slides that unfortunately, compared to other screening programs in the form of breast, mammogram, or even fecal occult blood test for colorectal cancer, PSA is actually not the most accurate. Its accuracy is somewhere between 40 to 50%. And that is because, there are other many conditions in the prostate can cause the PSA to be high. But it's important to still offer PSA testing because it's the starting point where we actually do further investigation for most patients. So if you have a PSA above 4, that will trigger the next line of investigation, which is often an MRI prostate. And if you have a normal MRI prostate, I'll tell you, you don't have to be worried about your prostate and PSA being high, because that is probably due to other non-cancerous causes. And if unfortunately your MRI does turn out to be abnormal, then that triggers a biopsy, and that's where we really get the process going for you. So I would still say that PSA might not be the most accurate test, but it's often the starting point where we really start working out and make sure we don't misdiagnose you or undiagnose you with any form of a prostate abnormality.
Yes, indeed. All right. Dr. Tan also mentioned that some smokers are actually at higher risk of getting prostate cancer. So we do have a question. Any tips on how someone can reduce their risk of getting prostate cancer?
Uh, so unfortunately, there's not a lot of insignificant risk factors or health preventive measures for prostate cancer, and that really explains why prostate cancer is so common today. And I don't think we have a lot of lifestyle modifications in the last 30 years, but we are seeing a lot of rising incidence of prostate cancer. And therefore, I will always tell my patient, I think in general, a healthy lifestyle is important, because that also, allows you to have a long life expectancy. You do have other comorbidities that will really affect your lifespan, and that is really part of healthy living. Back to smoking, I think we know that smoking causes bladder cancer. Smokers have 10 times the risk higher to have bladder cancer, something I'm always interested in. Smoking have higher risk of lung cancer, but in terms of prostate cancer, the association is probably a bit weaker in general.
Oh, Okay, I see. Okay. So next we have a question. Is sexually inactive men, do they have a higher chance for prostate cancer?
Yes. So I think increasingly a lot of audience do Google around, and I think there's one study, this kind of landmark that talks about if you have increased masturbation or sexual intercourse more than 21 times per month, that might reduce your incidence or chances of prostate cancer. But there is some flaws in the study design, and we most of the urologists will agree that in more ejaculation or masturbation might help to slightly reduce the risk of prostate cancer, but it's probably not the most important determinant whether you are going to have prostate cancer or not.
I see. Okay. Okay. And then another question on, can cycling increase risk of prostate cancer? I think just now Dr. Tan also
Yes.
made some comments about it as well.
Yeah. So cycling can increase. Cycling does not increase the risk of prostate cancer. Okay, that is what we all know. But the problem with cycling, unfortunately, is that it does cause the PSA to be a bit higher, and therefore, it will trigger a knee-jerk effect where the patients are worried about their chance of having prostate cancer. I had a patient who's an avid cyclist. When he came to me, his PSA was 18, which was 4 times the normal 4, and he was very worried. And he started doing 3 monthly PSA for like 6 months before he saw me, and it was always like 18 to 19. And I did an MRI prostate for him, and it was a completely normal prostate. So I think generally I would say that in summary, cycling does not increase the risk of prostate cancer, but because it might cause the PSA to be slightly higher, that might trigger some form of anxiety. And if you are concerned about your PSA being high, then probably you might want to see a urologist who will order our MRI prostate to decide whether there's a need to do a biopsy or what are your risks of having prostate cancer.
So indeed, also the sport does not increase the risk of
Yeah.
prostate cancer,
Yes.
but it's because of the sitting down. Okay, yeah. Okay, and then we do have a question. So this audience member mentioned that he has BPH and have been doing the PSA test every 6 months and constantly PSA reading around 7 to 8. Is this normal and not cancerous?
Yeah, I think that's a very good question, and this is not uncommon in the patients that we see today. And going back to the earlier question that I answered regarding PSA testing, and I think it should be always done somewhere between 2 to 3 years. My advice for this patient is that I wouldn't recommend such a frequent PSA testing because PSA fluctuates. And sometimes, I joke to my patient, it's like stock market, right? It goes up and down, and you get very anxious, or you get very reassured when it's coming down just a little bit. What I would suggest is that it's probably time to do an MRI prostate, because that gives you a lot more information. And if your MRI prostate just shows that, look, you just have prostate enlargement that's not cancerous, there's nothing suspicious about your prostate gland, then you don't need to do a 6 monthly PSA. I would defer to the current guidelines, which is PSA testing every 2 to 3 years. So my advice is that probably you might want to consider MRI prostate to get the more accurate answer that you want to hear.
Yes, indeed. So do consult your personal medical doctor for further guidance. Yeah, for this case as well. Okay. And then let's see. Is it possible to have a PSA 4 and it's benign? And the yeah.
So thanks, Mr. Paul. So certainly, I have seen patients with PSA 15, 18, which I mentioned earlier, and they just have prostate enlargement and non-cancerous. I even biopsy them because they were very, very worried, and it was completely normal. So it's possible to have an elevated PSA and having no prostate cancer.
All right. I have another question for Dr. Tan here. Can I find out what are some of the potential side effects of prostate cancer treatment? Since we are talking about
So
it, yeah.
yeah, I think towards the end of my slide, there are many treatments available. You can have surgery to remove the whole prostate gland. You can have radiotherapy to burn the whole prostate, or you can even have the latest focal therapy that's offered in some of the public hospital. We started this focal therapy program about 5 years ago in Singapore General Hospital. So I will tell my patient that firstly, prostate cancer is very treatable. Secondly, you have an a la carte menu of options that will treat your prostate cancer, and that's according to how aggressive your prostate cancer is, and also your life expectancy and what other medical problems that you have. So surgery will have its own, I will tell the patient that surgery is like a short downtime. You come in for a day, you do a 3 hours operation, you're home within 24 hours most of the time. You have a urine tube about 5 days, and that your downtime is very short. Probably within 2 days you have the whole thing sorted out. But you do have to get through that transient urinary incontinence that will last about 3 to 6 months. Radiotherapy is usually for patients who are not so fit. There's a longer downtime because you come every day for at least 5 days or up to 2 to 3 weeks to get the radiotherapy. It avoids the side effect of urinary incontinence, but it does have its own side effects, such as it might cause the prostate to swell a bit during the radiotherapy, so you might have a lot of difficulty or passing urine or a lot of urinary urgency. So if in it, what I would say for a la carte is like someone with prostate cancer and they have a big prostate, they might want to do a surgery because it kind of kill two birds with one stone, right? You treat the prostate enlargement, you also treat the prostate cancer. And last but not least, certainly, for patients with only a little bit of prostate cancer, they want to have it treated so that it doesn't spiral down in the next few years to become very something aggressive. Then that's the option of focal therapy, where we just put a needle and burn it, and that gives that kind of reassurance for the patient.
Thank you, Dr. Tan. So, here's a gentle reminder for those who have just tuned in. So, if you have any questions, please feel free to share in the comments, and we'll invite Dr. Tan to address them accordingly. So, I think there's a question that I missed out earlier on. So, is robotic biopsy available in public hospital?
So I think I would say that actually most of the public hospital nowadays do offer robotic biopsy, and in fact, most of them are using the platform that was developed in Singapore General Hospital. We call it the Mona Lisa to make it sound a bit sexy, but so I would say that most are available in the robotic biopsy is available in most of the public hospital.
Okay. And then one more question. I think you could have mentioned it earlier on. So, any tips on how someone can reduce their risk of getting prostate cancer?
So, what we always say is that I think it's very hard to reduce the risk of getting prostate cancer. We still haven't had a good solution or trying to identify what are the risk factors for prostate cancer other than age. But what we are all trying to do today, even the 365 Cancer Prevention Society, we are trying to detect early prostate cancer. And if you ask me as a urologist that's been practicing for the last 10 years, I think Singapore is doing a very good job. When I first started training 10 years ago, we are seeing a lot of stage 4 prostate cancer. Their PSA is like 500, 5,000. But I think, we have come a long way as a country doing, prostate cancer screening and PSA testing. And today we are actually picking up all the stage 1 prostate cancer, treating them very well, so that I think that's why you can see that the mortality is also one of the reasons why the mortality is much lower, because we are able to pick them up early on and treat them and give them that cure rate of 85 to 90%. And this is probably one of the cancer that is very treatable compared to many other cancers that one might have.
Okay. And Dr. Tan, we have a question. It's also my question as well, I guess. So, is free PSA a more accurate indicator? Is there a difference between a free and a paid PSA test?
Yeah. So these are what we call the derivatives of PSA. So PSA in general, we use the total PSA. Sometimes in the older days, we use this thing called the free PSA, because basically the PSA is a molecule. We want to see, when we talk about free, is whether this molecule is bound to a protein or is just freely floating in your body. And there's some suggestion that sometimes the free, in the older days, we tend to think that maybe the free PSA is slightly more accurate than the total PSA. But there were a lot of studies that follow up after that, and it seems that the whether you do a because most of us will order a total PSA first. It's whether you will order a free PSA on top of the total. I would say that most of us don't order a free PSA on top of the total because honestly, the additional information that you get from a free PSA is not very great. You are probably looking at, the total PSA. I would say that, we talk about the accuracy about 50%, right? Adding a free PSA will give you maybe another 5%. That will make it about 55 to 60%. But you're still 40% unsure whether you have prostate cancer. And that's why most of us, as when we see a elevated PSA, we repeat one more time. If it's still high, the next thing is that we probably want to consider MRI because that will give you, that kind of 90% accuracy that you don't get by doing more and more blood tests.
So as you are sharing about the PSA tests, then we suddenly have a lot more questions about coming in about is it possible to have a PSA score 0? Yeah.
Yes, that is only achievable through surgery. So if I do a robotic surgery that removes the whole prostate gland, your PSA is supposed to be 0, or what we call unrecordable. And that's what I tell my patients. So when I see them about 3 weeks after the surgery, I will show them the report of the where we take out it and look at under the microscope. I will also show them their latest PSA. So they are supposed to see, they might have a starting PSA of 8. After surgery, it should be 0, unrecordable, because you have no more prostate gland. It's not supposed to be high at all or even present at all. Unfortunately, I say that any form of treatment is not 100%. There's always about 15% chance of recurrence. Therefore, after surgery, we tend to monitor your PSA every 6 to 12 monthly. If you start to have recurrence of your PSA, such as like 0.1, 0.2, then that is where we talk about recurrence after surgery.
So with the question about PSA score 0, then we have another question. If a person has a normal PSA level of 3 to 4, would there be a possibility that he can still have prostate cancer? If so, how can it be detected if the score is so low?
So like what I mentioned, actually a cutoff of 4 is very arbitrary. Internationally, we agreed upon. The reason is because if you are less than 4, there's still about 20% chance that you have prostate cancer. That is the truth. But having what we call aggressive prostate cancer that will spread, will affect your lifespan. That kind of aggressive prostate cancer, we are talking in someone with PSA less than 4, the chance of you having that kind of aggressive prostate cancer is less than 5%. And therefore, that's why it's important. We don't need to detect all prostate cancer because many of them, they are non-aggressive. So we don't need to create that kind of anxiety for everyone. But that cutoff will allow us to detect the more aggressive prostate cancer that really will need treatment because it will have a higher chance of a spread over time.
So in general, it's just good to consult your personal doctor for further guidances if you have any questions.
Yes. So I think, where that kind of concern about PSA, that uncertainty, then probably it's best to speak to at least some of the GPs or even urologists to help you understand, what is useful about PSA, how can you interpret it, what is the shortcoming of PSA. So what else can you do to give you a bit more accuracy, that kind of picture.
We do have one more question here. So will BPH continue to enlarge and become a condition where there is difficulty to pass out urine to warrant a surgery?
So it's not uncommon for men above 60 years old at the same time to have prostate enlargement. And most of the large studies will say over time, about 10 to 15% of patients with enlarged prostate will need some form of intervention. That kind of warrants a huge separate discussion on its own. But what I would tell the patient is that nowadays, there's also a la carte menu of how you treat prostate enlargement. There are like at least 5 to 7 different surgeries out there for prostate enlargement, not prostate cancer. And a lot of them, is very tailored to the individual's wishes. So that is something that we will always discuss with the patient.
Yes, indeed. Okay. Dr. Tan, before we end tonight's session, do you still have anything you want to add on or you would like to emphasize to the audience that are listening currently at the moment?
So I think we have talked about prostate cancer being very common, and but I will always tell the audience that today with a lot of the health screening programs, not just 365 Cancer Prevention Society, but a lot of the GPs, what they are doing a lot of health screening that allows us to help to detect early prostate cancer, and that is very treatable nowadays. And that is probably something very heartening for everyone here, for the audience to know.
All right. As just as we were speaking, we can wrap up with this last question. Is there any other tests beside PSA and MRI? A
So
conclusion.
the short answer to your question is no. We heavily rely on PSA followed by MRI and then decide whether you need a biopsy. There's also many other blood tests you can do. One thing you might, I presume, if you ask that question, you might come across this thing called prostate health index or PHI. You might even come across some urinary or blood tests that will help to see some of the genetic mutation that increase, that is associated, some gene defect that's associated with prostate cancer. In Singapore General Hospital, we actually did all of them as part of our study. We got grants to do some of this. But at the end of the day, they were never as close as MRI prostate as in terms of accuracy. So you get your PSA testing, which is somewhere between 50%. You get MRI that's 90%. And in between this 50 to 90%, you have a lot of things, a lot of tests you can do, which is give you 65, 70%. But at the end, you will almost always refer back to MRI prostate as the last investigation. So is there a point to do many of these other blood tests in between before you do MRI prostate? I think most of us would say no, because it really adds up a lot of unnecessary cost to the patient.
Hmm. And just one last question I see coming in. So sorry, Dr. Tan. There's a question, since there is a risk of prostate cancer, what is your view on removing the prostate?
So two things. My interpretation is that is he Mr. Han, is he asking in a sense of if you have hereditary breast cancer, we talk about removing breast cancer, right? Angelina Jolie removed her breast cancer. No. Okay, so we don't prophylactically remove prostate just to prevent prostate cancer, because surgery or radiation will have its own side effect. Second, prostate cancer doesn't always cure. So if it doesn't always cure, then there's no point to removing the gland for the sake of removing, and let the patient suffer some deterioration in their quality of life.
So with that, thank you everyone for all your questions, and thank you Dr. Tan for your sharing and for answering all the questions from everyone. So now it's time for Dr. Tan to take his leave. Thank you so much for sharing with us your professional insights. Thank you.
Yeah, thanks, Carmen. Thanks everyone for logging in, and again, thanks to 365 Cancer Prevention Society for the kind invitation. And with that, have a good night. And if there's any question, you can always Google or find me or online, and drop me an email. Thank you very much. Have a good night,
Thank you,
everyone.
Dr. Tan. Thank you. Thank you so much.
Hmm.
All right. Do like, share, and follow us on our social media pages for the latest updates on our events. So, once again, thank you so much for joining us tonight. I hope to see all of you in the next session. So, take care, stay healthy, and good night. Have a wonderful weekend. Bye bye.